for joining us tonight for yet another of our panel discussions sponsored by STAR Hospice. Our good friends Ravi Shakamuri and STAR Hospice have done a wonderful job of putting together this series of panel discussions that feature some of our best and brightest physicians and healthcare professionals in Odessa and Midland to help us discuss various issues that affect our health every day of our lives. My name is Patrick CANTY. I'm the publisher of the Odessa American, and it's my privilege and honor again to host this panel. Tonight, what we're going to do is start what will be a three-part series dealing with all things diabetes. Tonight, we'll be talking about kind of learning more of the basics, the causes, the prevalence, the risk factors, screening, prevention, and the impact. Then for our second installment, we'll be dealing with various types of medications used to treat it. And then in our final installment, we'll talk about insulin treatment and other more extensive treatments. But for now, to help us get with this discussion, we have four wonderful physicians joining us tonight. Joining us is for a repeat performance is one many of us know and love is Dr. JAYARAM NAIDU. Then we have joining with us is Dr. SARA AMIRI, and then Dr. Ram Chimikanti, and last but not least, Dr. SURESH PRASAD. And so to kind of get things kicked off, I think what I'd like to do is go around the table and let each of you kind of introduce yourself and let us know a little bit more about you and your background, starting with you, Dr. AMIRI.
Hi, I'm Dr. SARA AMIRI. I'm a dual board certified internal medicine and pediatric physician. I'm fairly new to West Texas, moved here almost 2 years ago, and I work at ORMC as a physician advisor currently.
Super, glad you could make it tonight. Welcome. Dr. Prasad, tell us some more about yourself.
Hi, good evening. Actually, I have been here since 1997, and I started doing residency first at Texas Tech. And then I started my own practice in 2004. I'm board certified in internal medicine, sleep medicine, and obesity medicine, as well as in the advanced diabetes management. And I have my own private practice.
Great. Thank you for coming back. This is a repeat performance for you too, as well. So we're glad you're back.
Thank you.
And speaking of Texas Tech, Dr. Chimikanti, you hail from Texas Tech Health Sciences Center. Tell us more about you.
Hi, Pat. Thanks, Ravi, and everyone for this opportunity. So it looks like I'm one of the newbies. I've been here only 16 years. So yes, I'm with the Texas Tech University Health Science Center School of Medicine at Permian Basin. I'm the chairman of the Department of Internal Medicine, the regional chairman, and also the program director of the residency program. And love working here because I'm taking care of so many diabetic patients. I'm also board certified in endocrinology and diabetes. So it's fantastic to be here talking to you and the wider Midland, Odessa, Permian Basin population. Very excited to be here.
We're grateful that you could make it tonight. Now we go to the Odessa native, Dr. Naidu.
Yes, sir.
Tell us something that we don't already know about you, which is probably pretty hard.
I've been here for a long time. I had a lot of interest in diabetes, as I had 3 endocrinologists were my partners, including Golapudi, and Mandalavi is the first one, who stayed 4 years, and Golapudi stayed another 4 years. Therefore, I like doing a residency with them. And also I did the trials which they related to diabetes, about 13 trials, which includes Navigator trial, which is a landmark trial, Leader trial, which is also landmark, and Accord trial. I was participated in them. I think I closed my research about 5 years ago. That was a separate department I handled. And now I practice with another internist, and I have a special interest on heart disease and diabetes. And I introduced the Cardio Central, which is a rehab place. One interesting thing is, first when I came in and I was doing the blood sugar checks, and so I don't know the year, and they formed a committee on me to investigate. That's not the right thing to do. And that is in medical center. That's very interesting thing because it's an interstitial fluid, and I give insulin basing on that, which is not scientific, which became standard of care. That's many, many years ago when we had a lot of controversies on many things, including the cardiac rehab and diabetic care. That's what it goes in.
Super. Thank you so much for taking time to be with us again, because you've been with us on several of these programs. It's been wonderful. So before we kick things off, I just want to let our viewers know that if you have a question for the physicians, you can, I believe, enter it on your Facebook site where we're streaming. And what I'll do is I will kind of go through those as we go through our discussion, and we'll try to weave your question into our program. So with that said, I think what I'd like to do is turn it over to you, Dr. Prasad, to kind of give us kind of an overview of what diabetes is all about and the scope of it and the like. So go ahead and take it away and help us understand it better.
Thank you, Pat. Good evening, everyone, again. And what we will do is in the next 10 minutes or so, we will talk about the overview of diabetes. And I have some PowerPoint presentations, so we will start with the first slide. And then we will talk a little bit about risk factors. We will talk about the prevention, how to prevent. And then we will also talk about what is the recent guideline. So first of all, this presentation by all four of us are not intended to be substitute for a professional medical advice or diagnosis or treatment. Always talk to your provider or physician regarding any question related to your medical condition. And of course, this is a community education services, and we are not paid for these services. So just I wanted to have a disclaimer. Let's go next, please. So first of all, I wanted to talk about how diabetes is impacting all over the country and in the entire world. So in 2015, if you will look at it, we had about 30 million Americans suffering from diabetes. That was about 9.4% of our entire population. It is estimated by 2050, yeah, perfect, thank you. So it is estimated by 2050 that we will have about 84 million Americans suffering from diabetes. That is almost 21% of the total US population at that time. So, the prevalence of diabetes is going up, and so is the treatment modalities are going up. But again, somewhat the lifestyle modification needs to be changed in order for us to get better and better in it. Next, please. So what is the lifetime risk of developing diabetes if you are born in 2000 in America? So if you are Caucasians, your chance is almost 33%, 1 out of 3. If you are Hispanic woman, that is almost 50%, almost 50%. African-American and the Hispanic males have about 40% chance of developing diabetes if they're born in 2000, and if they continue to have the same kind of lifestyle that we are following at this time. Next, please. So this is a summary of whatever we have talked so far and some other things. This is the 7th leading cause of death in the country. The rate of the new patients with diabetes has increased by 90% in the last decade. Just think about it, 90%, it has increased in the last decade. 30 million Americans have diabetes, that is 1 out of 10. And plus, 86 million Americans are pre-diabetic. Pre-diabetes, it predisposes to diabetes. And that is almost we will talk about what is the difference between pre-diabetes and diabetes in the next few slides. 90 to 95% of diabetic populations are type 2. For the presentation today and in the next 2 presentations, we are going to mainly focus upon type 2 diabetes. We will leave type 1 diabetes, we will touch few aspects of it, but in general, we are going to avoid because it's an entirely different treatment modality, different pathogenesis, different pathophysiology. So we will talk mainly about type 2 diabetes, which comprise of about 90 to 95% of diabetic population in the country and all over the world.
So doctor, real quick, just to clarify, type 2 is the kind that you get when you're not leading a healthy lifestyle, pretty much.
That's exactly right.
Type 1 is something that's more a genetic
Yes.
predisposition. Is that correct?
No, so the type 2 has a high genetic predisposition, but the type 1 happen sporadically because of the autoimmune phenomena when your B-cell function of the pancreas is completely destroyed, or it also happens because of certain viruses. Like, there are certain viruses, Coxsackie B virus and some other viruses have been reported to destroy your beta cells. So the difference between type 1 or type 2 is you do not have no insulin in type 1. In type 2, you still have insulin, but also you have a lot of insulin resistance as well. So usually the type 2 happens in the patients who are overweight or obese. The type 1 happens mostly, in general, I'm talking about mostly in the thin person who are not overweight.
Right.
Usually type 1 happen in the early age, type 2 happen in the later age, but that is not the rule anymore, because in the next slide I will talk about, lately we have noticed that in the past when we were in medical school, we were taught that it's a juvenile onset, it's an adult onset. That's what we were taught. But nowadays we are seeing a lot more younger population or a lot more children developing type 2 diabetes because of our lifestyle, because of obesity, because of diet, because of sedentary lifestyle, and the food habit. So, that's what I said, the 50% of the children we are seeing nowadays, I don't see any patients who are less than 15, but I have a youngest patient, at least a dozen of them below 20 who are diabetic. And we did some blood work to find out whether they are type 1 versus type 2. And we find out that they are all negative about all those autoimmune testing that we do. So they're that is very alarming. That is very kind of worrisome for our children. And that is the reason why it is so important to have a very regimen lifestyle, diet, exercise, weight loss is very important.
So Pat, another way of looking at type 1 and type 2 diabetes is, type 2 runs in families, even though we don't realize it. When Dr. Prasad says there is more genetic predisposition on type 2, there is multiple factors, environmental and genetic, that are molding the cause for type 2 diabetes. And type 1 diabetes is a much smaller population, and there are multiple theories explaining it. We'll focus this conversation on type 2 predominantly because there are factors that are modifiable, which we will talk about in this panel discussion. And then there are certain factors that are non-modifiable. Dr. Prasad showed this very nice slide that if you are born in a Hispanic American family or an African American family, that risk of you having type 2 diabetes is higher just because of your ethnicity. And then depending on the gender and certain other factors, they are non-modifiable. You're born with them.
Right.
You can't change the family you're born into or the condition you're born into. But then as this panel discussion goes, all of us will share our thoughts about what we can do to prevent diabetes or reverse the pre-diabetes and see how we can decrease the impact diabetes has on most of our community.
Perfect.
Perfect.
I think before that, let us see how we can diagnose prediabetes. Prediabetes is defined like a blood sugar between 100 to 125. World Health Organization says 110 to 125 fasting sugar, or postprandial after glucose load if it is 140 to 199, and the 5.7 to 6.7 is a high risk group, less than 5.7 is also pre-diabetes. But when we stamp 80 million people with pre-diabetes, do all of them become diabetics? No. 2% every year of that pre-diabetes will become diabetic. But if you take 10 years, that 80 million people, only 10% will become diabetic. Therefore, are we scaring the public, telling, oh, you have 105 blood sugar, you are a pre-diabetes? Is it giving some ammunition to the insurance companies? Therefore, it's important to warn them. You have, the sugars are higher, and you have a risk to become a diabetes. And another thing is, the type 2 diabetes also genetic, impaired insulin secretion. Some genes have been discovered along with environmental. Insulin resistance also gets genetic, and which can elevate the glucose. Therefore, there is a good genetic factor goes on in diabetes. Average risk of siblings is 30 to 40%. If one parent got diabetes, 30 to 40% children will become diabetic. If both parents got diabetes, 50 to 80% become diabetes. Same thing with twins, monozygotic twins, 50 to 90% both become diabetes. Therefore, genes, which are coming more and more now identifying, there are more genes being identified for type 1. But there are some patients, like if I have a Hispanic patient, 80-year-old comes in, and her blood sugars are ranges from 60 to 400. And when we check, she may be type 1 diabetes. Therefore, number thing, if we get a diabetic new patient, one important thing for us is to determine whether it is a type 1 or type 2.
Right.
Therefore, the treatment quite different in these two patients. One needs insulin, another needs medication for insulin resistance, and also lack of insulin.
Okay.
And see what the other panel members talk about genetics, and along with environmental, and also about pre-diabetes. Are we right telling pre-diabetes for so many people? Because 460 million people in the world or more becomes that. Therefore, pre-diabetes is a nice way, but don't put it as a diet disease. Like that probably can warn them, but can't stamp them as a disease.
Absolutely, Dr. Naidu. Because with the pre-diabetes, I think what's important is that we're screening, right? This is one disease that we can actually screen for. So what's screening? Screening we can't do for all diseases. Some diseases, we have to see it present itself. It presents itself through symptoms. With diabetes, if we wait long enough for the symptoms to be present, that's too long, that's too far out. It's already done damage to your body. So that's why it's important to screen for diabetes. So when we screen for diabetes, we can detect that your sugar levels are a little bit higher than what they should be. You're not a diabetic, but you're a pre-diabetic. We, as physicians, we label you as a pre-diabetic. It's not to scare you, as Dr. Naidu said. It's to tell you that you're in danger of developing diabetes. But you know what? If you change the way you live your life, you can actually reverse it.
Right.
With diabetes, we generally cannot. By the time you reach the diabetic level, we cannot reverse it. We cannot cure it. You're going to need medications. But with pre-diabetes, we can actually reverse that. So that's
Good
really
point.
important for patients to know and to not be scared about it.
Right.
So one of my mentors says, genes set the stage and
That's
environment plays the part. So that goes back to the same feature. There are a few things that you can control and there are a few things we don't. And when we are saying higher risk for diabetes or pre-diabetes, we are saying diabetes presents a unique opportunity. It's a very difficult disease to manage. Can we wear a mask to prevent it?
Yeah.
Or can we do something to prevent it? I think all of us agree that we can.
Exactly. So we're going to find out some more on with the PowerPoint of kind of how to diagnose it, those at risk, and how to prevent it. So let's see, what is, okay, here we go. Diabetes, and just go ahead, Dr. Prasad.
So actually, there were a couple of points. The diabetes is the leading cause of amputation of the leg, blindness, and kidney failure. It's very important, and this is the biggest epidemic, not in the country but all over the world. We have about 425 million people suffering from diabetes. Next, please. So as the obesity prevalence has gone up, if you will notice here, this is the data from 1990. The Texas was in less than 4%. Then it became 4 to 6%.
Wow.
In 2000, it became almost 6%. And now we are close to about 9.5, 9.6% populations of Texas is diabetic. Next, please. And again, the same thing, increasing body weight increases the risk of diabetes. This is the data from UpToDate, and this is we have reiterated that several times. Obesity, in my opinion, is one of the biggest risk factors. We have seen it in patients with bariatric surgery. The diabetes, as Ram was saying earlier, it cannot be cured, but it, to a certain extent, it can halt the process if it is not genetic. Next, please.
Okay.
So Dr. Naidu has talked about pathophysiology, and so I will let him discuss that. But 3 things that happens in the patients with diabetes type 2. The first thing that we all should know is insulin resistance. And that comes from being overweight or sedentary lifestyle or inactivity. Second thing that Dr. Naidu also mentioned, Ram mentioned about the insulin deficiency. There's really relative lack of insulin or relative insulin deficiency. It's really not absolute deficiency of insulin as we see it in the type 1 diabetes. So the both insulin resistance and insulin deficiency happens in type 2 diabetes that leads to high blood sugar and diabetes. In the type 1 diabetes, you would probably not see insulin resistance, but you will see complete absence or related absolute deficiency of insulin from the beta cell function. So we are going to ignore type 1 in general. We are going to talk more and more about type 2.
Okay.
Next.
Yeah.
Real quick.
The deficiency in insulin secretion is mostly due to genes. The need for higher amount of insulin is genetic and environmental. That's the difference. Obesity is the main reason for resistance. What do you think, Ram and Suresh?
Yes, sir. I agree completely.
Because the deficiency is due to genes.
Correct.
Okay.
Whereas resistance is both genes plus environmental, like obesity and how they eat and what their lifestyles are.
Sure.
So Norma Rodriguez, one of our viewers, did ask, wants to know exactly what does insulin resistance mean?
Insulin resistance is insulin is present in large amounts. The pancreas is trying hard to keep the sugar down.
Okay.
Then it produces a large amount of insulin. But the insulin don't get into the cell. Cell will close the doors. It's not letting the insulin to get in. That is the resistance. The insulin is not able to work. Therefore, we give some medicines to make those windows open for the insulin to get in.
Okay, great.
So some lifestyle changes for the insulin to get in.
So when you eat food, when you eat carbohydrates, the carbohydrates are digested in your stomach. It's digested into sugar. Sugar enters your blood vessels, and then that's your energy, right? You get energy from sugar. Where does the sugar need to go to work? It needs to go inside your cells. So if it's going inside your muscle cells, then your muscles will have the energy to work. In order for the sugar to enter, you need insulin. So the insulin is produced by your pancreas, and it helps. It's almost just like Dr. Naidu said, if you want to think of it as a door or a lock, the insulin unlocks the it's a key to unlock the door,
Right.
to let the cells in. So you can have problems where you have no insulin production, right? The cells that in your pancreas that produce insulin do not work there, and that's the type 1. What we're talking about with type 2 is a lot of times it's insulin resistance. You start off as those cells no longer respond to that insulin. They're not seeing it. The lock has changed.
Okay.
Does that make, I hope that makes sense.
That's
Absolutely.
right. Yeah.
So that's fascinating what our panelists said. So Pat, it's kind of a paradox, right? Diabetes is a problem of high blood sugar. But guess what? Like Sarah just said, the sugar is not where we need it. So our muscles, our body is actually starving for the sugar and the water that needs to come with the sugar, but our sugars are high. So, so our body is in a state of starvation, and we are doing everything to take care of that starvation. Our brain is saying, go get more food because we are starving, right?
Right.
Our liver is making more sugar, trying to say, how do I keep up? I'm putting out sugar, but
I'm too much.
But it's not getting where it needs to go.
It's not going where it needs to go. So there is a fascinating discussion to be had in a separate time where this paradox kind of explains a lot of what happens in diabetes.
With the symptoms, right, Dr. Rama?
Yes.
Is that what you mean? Yes.
Symptoms, complications, everything. And luckily, when we have increased our knowledge on these topics, we have said, oh, this is the problem. The liver is putting out too much sugar, even though there is already so much blood sugar. So can we stop the liver from putting out so much sugar, right? Or the kidneys are not peeing out the extra sugar, so maybe we can make the kidneys pee out extra sugar. So they have developed fascinating mechanisms where we now have treatments that we will talk in a subsequent conversation. But I want the viewers and everybody to understand the paradox that we talked about.
Okay.
Perfect.
Those are 3 incredible explanations.
Yeah.
Go ahead, Dr. Prasad. Keep
Sir.
going. You're on a roll.
Yeah. No, so actually, I hope it is clear, because all 4 of us, we have said enough about insulin resistance that we see mostly in the type 2 diabetes, not much into the type 1, or very, very less in the type 1 diabetes, because there is a different mechanism. All right, so we will talk about, as Ram was saying, how the medication works. There are certain medications that decrease insulin resistance, which works on the muscle, which works on the liver, which works on the kidney. We will talk in the next slide, next presentation in the next time. All right, let's go to the next time. All right, so this is very fascinating slide, as Dr. Naidu was mentioning earlier about the pre-diabetes and diabetes. So by the time, go one more slide, please, sir. Raghu? Yeah, perfect. So there is a landmark study called UKPDS data that has shown that by the time you are diagnosed with diabetes, 50% of the beta cell function are gone. 50% of beta cells function are gone. And normally—
Don't you think UKPDS was done on type 1?
No, type 2.
No, sir.
Dr.
No, type 2,
which
sir.
one? Which one is type 1? The large study was done many years, 1977.
Are you talking about DCCT trial? DCCT trial?
Yeah. DCCT
trial.
Yeah.
That
DCCT,
is,
yeah.
I'm talking about DCCT trial. Correct.
So again, this has shown that it takes normally 7 to 10 years for you to be developing diabetes. So you might be in this area where you have pre-diabetes when your fasting sugar is a little higher, but by the time you are diagnosed with diabetes, 50% of beta cell functions are gone. And it's a progressive disease, and of course, if you gain weight, if you are not eating healthy, if you are not doing exercise, you add on to it, and sometimes you can develop even sooner than 7 to 10 years. It does not have to have 7 to 10 years. Next, please. So again, as I was talking earlier, 50% of beta cells function decline happened at the time of diagnosis of diabetes. And the reason I wanted to point it out, and again, we will have this discussion in our next presentation. There are certain medications which works from 50% beta cell decline to 25%. But once your beta cell decline happens below 25%, then you're basically acting like type 1 diabetic, and you are going to require insulin therapy because there is no medication, oral medication, which are going to make your body produce more and more insulin. So once your beta cell function is down below 20%, you are going to require insulin therapy. The next, please. All right, so every diabetic should know there is a term called ABC. And if you are a diabetic, you should go and ask your provider, what is your A1C, and what is your blood pressure, and what is your C is LDL-C, that is a bad cholesterol. So the hemoglobin A1C, as per American Diabetic Association, it should be less than 7%. So you should know that what is your hemoglobin A1C. If it is above 7%, then I think your provider should act on it and try to keep it below 7%, unless your life expectancy is less than 10 years or so. The blood pressure is the second. There's a B stand for blood pressure. Ideally, blood pressure should be 140/90. This is the last year data. But in general, we try to get it to the goal below 130/80. That is the general goal. The LDL-C is this bad cholesterol, or a statin therapy should be given to every diabetic who are 40 years of age, and if they have diabetes, they should be on a statins. And the data has shown that the most of the diabetic that do not die because of high blood sugar or because of low blood sugar, because they die because of the heart attack or a stroke. So that's the number one cause of death in the diabetic population. If you have diabetes, your chance of having heart attack is higher than somebody who already had heart attack. So the LDL-C should be taken care of. If you're 40 plus diabetic, you should be on a statin, no question asked. That is the guideline. Again,
that means if you have a diabetes, you have a heart disease. Is that right? For
Yes,
people to know. If you have diabetes, you have a heart disease.
That's exact. So there is a term called coronary artery equivalent. So if you are a diabetic, as Dr. Naidu said, you have heart disease. That is a term called coronary atherosclerosis equivalence. So yes,
East-West study, yeah.
Yes, sir.
And
so
also, like ABC, you said, another one is rule of 6.
Mm-hmm.
That means, A1C 6 or 7 between. Blood pressure, mean pressure is 60, like 120/70 or below. Or BMI is 26. LDL is below 60. HDL is 60. And we call rule of 6. Therefore, people should know their numbers. My numbers are these. Write down in a slip. Am I reaching these numbers? Therefore, when you reach hemoglobin A1C 6.5 to 7, you can prevent your eye problems, kidney problems. But in old people, you don't want to bring it below 7 because they get into ACCORD study, which I was a part of it. You had more mortality with low sugar. Therefore, you can tell 7.58 is all right for 80-year-old. Or a nursing home patient 90, I don't mind them to have 8 to 8.5 is all right, because you don't want to give them more medications to bring because the macrovascular is the only one which changes when it goes above 7.5. But below 7, the microvascular protection with eyes and kidneys. What do you think, the other panelists, on that? About A1C controversy?
I think, yeah. Suresh,
go ahead. No, go ahead.
So I'm excited. Dr. Naidu brings up another wonderful point. How low is too low, right?
Right.
We throw out numbers of 6.5, 7, 7.5, but we have to look at it in the perspective. First, step back, right? Step back and look at Dr. Prasad's slides of ABC. you can get a A1C of 6.5, but if your blood pressure is 180 over 100, guess what? There is ongoing damage right now to your heart and your brain.
Exactly.
Then as diabetologists, people get upset when I say, what was your blood pressure? Because they expect me to ask, what's my A1C, right? So just the diabetes, or it doesn't do much damage. These are all bad actors. So we have to put them and take a global picture and say, this is what we are going to work on. Yes, we want you to lose weight. We want you to get your sugars under control, but we also want you to watch your salt intake and watch your blood pressure and your cholesterol. So, and then the other point that Dr. NAIDU made about look at the person and then adjust your goals. Low sugars will hurt you now, right? A sugar below 50 has bad implication right now. So therein lies the other fascinating aspect of diabetes. So low sugars are bad. So I might as well be high. That is one of the thought distortions that we do when we don't want to step up on our diabetes management. My doctor said low sugars are bad, but high sugars will hurt you over a period of time.
Well, I think, and what happens with patients, right, when they have diabetes, the low sugars a lot of times affects them more. They feel more symptoms. They are tired. You do not feel good when your sugar is low. But if you have been a diabetic for a long time, your body is used to running on high sugar, you almost don't feel it. You don't feel it. You feel better having high sugars than low sugars. And that's why it's important to talk about your symptoms and talk about what is happening to your sugar, to your doctor, to your provider. You want to tell them that if you're having low sugars, how does it make you feel? Is it happening, right? It's not just about the high sugars are bad, low sugars are also bad. That's what we're all trying to say. And we need to know it so that we can adjust your medications, because we don't want you, absolutely right, we don't want you to have low sugars, especially in an elderly where the low sugar can actually hurt you more because it can cause you to pass out, fall, pass out, and that's not going to be good, especially in an elderly patient.
Right.
More ER visits, more hospital admissions are because of low sugars. That's one point. If you see ER visits, more due to low sugars, or if they are in sulfonylureas like glimepiride, glipizide, we have to admit them with the low sugars. Therefore, that's an important thing, not to recognize low sugars, to avoid low sugars. That's a different discussion. Let's go ahead.
Okay.
I think also it's important to know not just your ABCs, your numbers, but also know how often you need to check those numbers. Because a lot of times I see patients where they get their A1C under 7 and they're like, I'm good.
Yeah.
I'm going to stay on the same medicines. I'm good. I'm not going to see my doctor for another year. Okay. That's bad, because diabetes is a progressive disease. Even if we have you on the perfect medications and we have all of your numbers controlled, all we're doing is slowing down the progression of the disease. We are not stopping it. So we're just slowing down the damage that's being done to your nerves. We're slowing down the damage that's being done to your heart vessels. That's all we're doing. The damage that's being done to your kidneys, to your eyes, because diabetes affects every single organ in your body. So we slow it down. We want to slow it down, right? We're helping you live a longer, healthier life, but we're not stopping it. So for a hemoglobin A1C, if your hemoglobin A1C is above 7, you need to have that repeated every 3 months.
Right.
Okay.
And
because
also one more thing,
Sarah,
I would like to tell, with the experience what I have, the empathy and mindfulness is very important.
Right.
If the patient don't come to you when their hemoglobin A1C is 11, they're scared to come to you. Just have some empathy. I won't worry about 11. Just tell them, you're doing all right. Let us try next time. Rather than getting onto that, you haven't lost weight. Your weight is still high. Your hemoglobin A1C is high. The guy has already got a stigma with the diabetes. And when he's scared of the doctor, he won't go. But he has to be empathetic
For sure.
work with them. It's a teamwork.
Absolutely.
And also, we don't refer to the dietitians here. Not many dietitians. Go to dietitian, you can get 1% A1C down, just going and talking twice to dietitian. Therefore, why are we not doing, not even 5% of the physicians send their patient to dietitians, and we know very little about the diet.
Right.
As far as I'm concerned, myself.
Sure.
And my wife better knows more than me what I should eat. The doctors are not good with the diet. Send them to the specialist who knows much about the diet. What do you think about that? Sending more patients to the dietitians.
So I think, Suresh, you want to go ahead?
No, go ahead, Ram. Go ahead.
So I'm just, just hearing you speak, I think diabetes is such a unique disease, right? There is no disease like diabetes. And I say that with a lot of empathy, because blood pressure, take your pill, forget about it. Check your blood pressure when you can. Go check your blood pressure in the doctor's office. Cholesterol, take a pill, repeat your lab in 3 to 6 months, cholesterol is fine. Guess what? Diabetes impacts each aspect of your life, right? The stigma or the sense that Dr. Naidu referred, it impacts what am I going to eat for breakfast? Can I go exercise after or not, right? What should I plan as a meal for my family today, right? Why can't I eat what my spouse is eating? Right? Yeah. So diabetes, that's what makes it so challenging, because it burdens you. As a patient, it burdens you. Not that people don't want to take care of it. Yes, we are working on efforts to decrease the cost of medication. We are doing things like that because that's a part of the problem. But just the fact that it impacts the way you live, and eating is precious to us. It's culturally, it's a part of us. So to let go of things that you like, or it just puts you in a very bad spot consistently. So I think empathy is significant and important part of your treatment. And we have to trust the medications we do, but we also have to trust that the patients with repeated feedback can work on the lifestyle changes and diet.
Well, right before, we're kind of running short of time, and Suresh, I'm going to ask you maybe kind of go through maybe summarize our remaining slides. But that's so important that y'all are talking about that, and it goes to the earlier thing about the pre-diabetic status. To me, it's just that one disease that really highlights the weakness of the human being. We love to eat. We love to drink. We love to do this. We love to love life. And unfortunately, a lot of us like to do it, and we get into the habit of doing it too much. And it's the one disease that it's almost like you're on a train track and the train's coming and you see it coming. You go into the doctor, you get your blood work, and they say, look here, this is going up. You can change this, but this is what you have to do. And a lot of us are like, okay, I'm going to, and then you fall off the wagon and you go back and eat too much. And it's one of those vicious diseases that we kind of bring upon ourselves that we could prevent ourselves. And then after we're diagnosed with it, sometimes we're not too good at following it, and we get ourselves in even more trouble. And so,
true.
Anyway, I'll be quiet and let
I've been meaning to say one thing. If there is one thing that we can take out of my impression is pre-diabetes is a precious phase. We are actually developing an app to predict the risk for diabetes and the risk for pre-diabetes, because some of the larger studies in diabetes prevention have shown that being high risk for diabetes also increases your risk factor for the problems we have with fully established diabetes, because the stage is set 5-10 years before you're diagnosed with diabetes. And it's a precious phase where we can delay or prevent the onset of diabetes. And in some of the early diabetics, if we intervene with 7% or 10% of loss in body weight, we can, at least for a period of time, reverse diabetes. I don't want you to minimize the impact of prediabetes because of the population at risk, but I think there is an opportunity there where each one of us can assess the risk on an app and say, I'm going to do this, because there are a few things that we can control. Like we said, we cannot control where we were born or the color of our skin. So we can't change what we were born with, but there are opportunities to modify our risk.
Yes, lifestyle changes become so important. It showed on DPP trial where 3,000 patients with lifestyle changes was better than the medication. Therefore, controlling the weight, how you eat, environment, exercise, and also your mind, happiness is very important,
Exactly.
and depression usually makes it worse. And not to worry, just be happy. That's good for diabetes. And that's what I feel about it. Just all this it takes a village to face diabetes, not the patient alone.
Individual.
Dr. Prasad, the numbers you show is shocking, how fast it's growing in this country. And Dr. AMIRI, I would think that, you dealing with pediatrics, that has got to kind of be a real gut punch when you see these youngsters coming in and they're already their backs up against the wall, and they're already.
And you can see it. And a lot of times it's an opportunity. That's why I love practicing both, just like family physicians, I guess, because it's an opportunity not to just intervene for the child, but also for the whole family. Right. Because the child is, yes, you're born with your genetics, right? So certain things are already set, but the food that you're eating, the amount of activity that you're having or not having really significantly impacts your risk. And we are seeing it at younger and younger ages, but that's okay. We can make changes, right? We have opportunities. So not being scared to address the issues is the most important, because if you just put the blinders on, it's not like the problem's going to be gone. It just gets worse over time. So it's better to address it as early as possible. So ask your provider, should I be screened for diabetes because I'm overweight? Should I be screened for diabetes because I already have high blood pressure and high cholesterol? Or if you're a woman and you have polycystic ovarian syndrome, should I be screened for diabetes? Those are important because we can catch it early, right? We can diagnose you early, and it doesn't mean you have to be on insulin shots. That's the other thing people are scared about, is that they don't want the shots, or they don't want to even check their sugars, right? Because that's scary to a lot of people. People don't like that. It's not an easy thing to do, especially if you have to do it multiple times a day. But you don't have to do that. If you're early in that process, you don't even have to, a lot of times, just even check it once a day, because we can just do your regular blood work and maybe you're just on metformin, and that's okay. You don't need to check. Right. So the sooner you address it, the less problems you're going to have, and it's going to take less medications, less interventions. It interferes with your life less, right? It's much easier to take one tablet, right, once a day, twice a day, versus taking several tablets or having to inject yourself.
So real quick, what are some of the symptoms? For example, a parent with a youngster, what are some of the telltale signs to look for? Someone mentioned, one of our viewers said something about patchiness on the neck, or gray patchiness on the neck of children. What are some of those things that we can check each other and our kids for?
Right, so that's called acanthosis nigrans, and that's basically, it indicates to us insulin resistance. So you might be prone to that, and so that's another thing to check for, absolutely. With type 2, so again, we kind of go back, because when we talk about children, right, it could be type 1. Type 1 diabetes presents very quickly and very dramatic. And we're not talking about that during this session. But the type 2, it's a slow, long process. And by the time you have the symptoms, if we check your hemoglobin A1C, it's probably going to be much higher. It takes longer. But people usually have complain of increased thirst. They're thirsty. So they've noticed that, I've had patients come in, I've been more thirsty over the past few weeks, I've noticed, or I've been going to the bathroom a lot and urinating more frequently. They're waking up a lot during the day, during the night, and then also during the day. Blurry vision can occur. Those are some of the common symptoms: fatigue, tiredness. Sometimes you can actually have a loss of weight also at that point where you've been going for so long. So you'll see a loss of weight. So it's not necessarily you'll be as an overweight person, you're more at risk of having diabetes, but at the time that you have it showing up in your body where the symptoms get a lot, you might have a loss of weight.
So
go ahead, I'm sorry, Dr. Rama.
Yeah. So one thing is, if they are consistently over the 95th percentile on their growth charts, that's a problem in their weight.
Okay.
So that is one thing that parents have to watch out for. And, I want to give a shout out to Ravi Shakamuri. Before the pandemic, we were actually creating a program where we would educate higher elementary school kids and middle school kids about taking ownership of some of their health, because one of the motivators that we were discussing is who can affect change in you better than a grandkid or a grandchild saying, "Grandma, what's your sugar?" or "Grandpa, what's your sugar?" So the COVID has kind of dampened some of our efforts, but I'm sure we will pursue the school health program that we were talking about, where we are empowering kids to ask health-related questions and increase health awareness.
Exactly.
I've had a number of kids who've been able to convince their parents and grandparents to stop smoking, for example.
Yeah.
So kids can be very powerful. Definitely use them. But absolutely, the weight is very important. And it's not, in kids, you also have to be sensitive, right? The same with adults, actually. I think a lot of times, I wouldn't like it either, right? Most of us, we get labeled, right?
Oh, sure.
You're obese, you're overweight, and my doctor is blaming everything that I'm feeling based on that, right? That's not what we are saying. Again, empathy, as Dr. Naidu said, right? We're all struggling, especially during these times, right? Especially during COVID. I don't know, all of us have gained the COVID 20, okay? So that's something that we all struggle with. It's not to make you feel bad. And with kids, we want to be sensitive to that, because we don't want to set the pattern for eating disorders and things like that. So you have to be careful, but having a discussion together as a family and a provider really leading that discussion of how do you discuss healthy lifestyle, right? It's not about what you look like, it's about feeling good and feeling healthy. So what helps you feel good, right? Does it help you feel good to eat, 2 bags of chips a day, or, have the candy, or does it make, help you feel better if you're eating more vegetables?
Right.
But does it also mean that I tell kids, you can't have cookies? No, that's not it, right? So it's a balance. We have to still live life and enjoy life.
Right. Oh, exactly. But
don't stuff it. Just eat until you're satisfied.
And you know what? If you did it one day, it's okay, right? It's okay.
Don't beat yourself up.
Don't beat yourself up.
Make the next decision.
Next day, wake up and try again. And that's what life is, right? That's what everything that we want to do. You don't just, wake up and say, I'm going to fix this and it's done, right? It is a daily struggle, but don't think of it that way. Think of it more positively, and give yourself room to make mistakes, to, be happy because you did eat a whole bag of chips. It's okay.
I guess the scary thing about, the scary part is with diabetes is eventually you have to take it seriously.
Yes.
Or else you get to the point where it's out of your hands and your body's just decided, I'm going to start shutting down and I can't just take insulin again. And I can't just, and then again, I think you were going to get to the slide, Suresh, about in COVID, if you're diabetic and you get COVID, it is not a good prognosis. And so that's what I think is a scary thing about diabetes, is you can do so much to prevent it and you can see it coming, and then you can get it and you can live with it. But also,
Pat,
if you don't
one
take
thing
it
I
seriously,
can,
it could get you.
Pat, one thing I want to tell, it's a new epidemic. How did we get here? We talked about eating, it's increasing many folds, diabetes, but there are some good things happening too. A lot more diabetes is here, but new medicines, 95 metformin came in. When I started, I have only one medicine called diabetes. So I've only one medication and insulin, and one type of insulin, is a big needle. And we have come a long way. Now with the new medications, we're targeting the disease and fewer complications. New diabetes medications may lead to even fewer complications. A lot of things happened since last 2 years. A lot of excellent medicines have come. Therefore, these are all good things happening too. Not only bad things, diabetes going up.
And then
new medicines are coming.
Just continuing what Dr. Naidu just said, if we take good care of it, diabetics will live to be grandparents, great-grandparents, they'll live a normal life. So
right.
That is very important to remember, that it's not all downhill.
Exactly.
So we are trying to prevent diabetes. We are trying to delay the complications so people live a healthy, productive life. So it's very important for people. I think all speakers on the panel will agree that it's not a death knell. It's a condition that we live with and we manage.
Right.
And one other cheap trick that I want to tell people, in West Texas, the sun's out most of the time, unlike last week. So if you think you're hungry for a burger, you're not. You're just thirsty for a glass of water.
That's good.
Yeah, right.
You are not thirsty for a soda. You're not hungry for a burger. You're just thirsty for a glass of water. Please drink a glass of water before you make your meal choice.
There you go. Dr. Prasad, go ahead, Dr. Amiri.
I wanted to say 8 to 10 glasses of water a day. And I'm one of those I'm horrible with water, but we all need to work on it. Have at least 1 to 2 glasses. I mean, start small, right? Just have a sip every morning before you eat or drink anything, or drink your coffee. And then you'll see that if you practice it every day, you'll actually drink more and more. And if you can get yourself to drink, 1 to 2 glasses of water first thing in the morning, you're already 1 to 2 glasses ahead, so that helps. And I fall off of it all the time, and then I start again,
Right.
But that's important, and you can work on it.
That's a good point. Dr. Prasad, what can you, I think it's getting time for us to wrap this up. Yeah. So I want to throw it to you and just kind of give us some parting thoughts before I kind of summarize and throw it to Ravi.
So actually, like, we had an excellent discussion from all the panelists, and there's a very, very practical point Ram said about the water. I just want to talk about the Coke or soda, not talk about the brand, but the soda. I was surprised to know the one soda has almost 9 spoons of sugar in there, 8 to 9 spoons of sugar, depending upon which brand you buy. 140 calories, that is coming entirely from a simple sugar. If you drink one soda a day for 1 year, you gain about 16 pounds of weight. So yeah, you should be thirsty, but not for soda. Go and drink water. That's very important.
I did not know it had that much sugar.
Yeah, 8 to 9 spoons of sugar, like a spoon of sugar, just one soda. So please try to avoid, follow, do exercise. Recommendation for exercise is about 30 minutes per day or 150 minutes per week. Like, try to be, as Ram was saying, 5 to 10% of weight loss will make a humongous difference in your hemoglobin A1C, the complications of diabetes, as I was showing earlier, 1% hemoglobin A1C reduction causes 14% mortality reduction. Same blood pressure control, diabetes control, blood sugar control, cholesterol control, weight control. These are all it's not a one disease. Blood sugar is not one disease. It's a complex, very complex, as Ram was saying. It's a unique disease itself. And 1 hour is absolutely not enough to discuss about the basics of diabetes. We can like, I have spent so many hours with Dr. Naidu and Ram. We can go on and on and on, and we can talk all night long, about those kind of things. So I think we are running out of time. Let me show the last slide, and then the impact of COVID, especially this situation right now. We are in COVID era, and if you will look at the go to the next slide, please. So if you are a diabetic, the chance of complications hospitalization goes up by 3 times higher. And this is another. This is the data from ADA just published right now. If you have COVID and diabetes, the hospitalization goes up by 29% versus 6% without diabetes. So guys, ladies and gentlemen, it's very, very, very important, especially at this time in the pandemic time of COVID. Try to get your sugar under control and blood pressure, cholesterol, and weight under control. And as all 4 of us, we have agreed that it's not a death sentence at all. We can control it. We cannot cure it, but we can certainly control it. And there is no reason why you would not have, you can see your great grandchildren. You should be living a very healthy lifestyle. If you today, I just want to share 10 seconds. I saw a 98-year-old patient in my office today. 98-year-old. She's diabetic. I have been following her for the last 18 years. Her hemoglobin A1C has been 6.5 to 8. 6.5 to 8. She goes to 8. She start dieting and all those. Today it was 7.2. So yes, it is doable. We all can do it. And never say that I'm too busy to do it. Never say. No. If you say that I'm too busy to do it, you are sending a wrong message to your own body. You're sending to your own soul. So always say I'm easy. If you do so, then you send a good message, good vibration to your body and your surrounding, your relationship, your family. So I think that's all. We had a wonderful discussion. Thank you all panelists. Thank you, Pat. And of course, thank you to Ram and Ravi and Sarah and Dr. Naidu for doing this. And we had a wonderful time. So I think, yes, sir.
Thank you so much.
Dr. Naidu, you said we need a village, and we are creating a village here in Permian Basin.
I think we need
and we need to invest more, but I think we have started creating that village so we can do well and Ram, keep working at it.
Can I tell you one thing? In nationwide, one endocrinologist for 6,000 patients. But here in Permian Basin, we have 5 endocrinologists and our population is 500,000, avoiding the other. We need more people.
So Dr. Naidu, we are here in the Permian Basin, the only endocrinology fellowship in the entire West Texas area.
I'm so glad you got it.
Lubbock doesn't have an endocrinology training program. El Paso doesn't have one, neither does Amarillo. I'm so proud that we have something here in Permian Basin that the rest of West Texas, and we are doing our best to address that need.
Absolutely.
I'm very proud of that. I really am proud of that. We have to produce more endocrinologists, make them to stay here. We need more people.
And Dr. Naidu, when you say you've been here so many years, we are all reaping the benefits of your vision.
Oh, thank you, sir.
Because you started this almost 40 years ago. So
thank you.
We'll make sure.
He has set the bar so high, Ram. It is harder to achieve that kind of, I always, like I told Dr. Naidu several times, when I grow up, I want to be like him. And
so there is no room for being ordinary. All of us have to be visionary.
Well, thank you all so much. And to our audience, I guess you can see that we're probably going to have not 3 of these installments, but 4, because just so you know, we decided we were going to go through Dr. Prasad's PowerPoint and discuss it as we went. And there was so much to talk about, given the fact that all of the guests here are so shy and it was so hard to get them to talk. We got it about halfway through. But anyway, I can't thank y'all enough. The information that y'all have, the compassion is so evident, and we're so fortunate to have all of you here. taking care of us. And please join us for our next installment, because I'm willing to bet that we'll probably have to have 4 of these, because there's so much to talk about, and it's so worthwhile. So thank you so much. Thank you for joining us, and I'm going to turn it over to you, Robbie. Thank you for having us.
Pat, thank you, sir. Absolutely wonderful. And thank you for hosting and coordinating this discussion, especially in the context of educating our community to be that much more conscious of so many things that we can do better. So Dr. AMIRI and Dr. CANTY, Dr. Prasad and Dr. NAIDU, we appreciate all of your time, volunteering your knowledge and your expertise, and able to connect to our community members. And as Dr. CANTY said, the dream is getting our kids also to be that much more be in charge of our family's health, as much as the adults taking the responsibility for themselves, and our seniors wanting to spend time with their grandkids as much as they can. So we will turn around Odessa into a healthier and even Permian Basin into a much more stronger community, but with your support and knowledge. So we thank you for that. Okay.
Thank you.
And in 2 weeks, we will regroup and go back into diabetes number 2, where this panel members will be discussing as intensely as ever and as passionately about treatment options for diabetes. So gentlemen, ladies, and thank you very much. Have a good night.
Thanks,
Thank
Pat.
you.
Thanks,
Thank
Ravi.
you.
Take care, everyone.
Thank you all.
Thank you.
Thank you.
Thank